Good morning to all of you. I hope we all enjoyed the meeting. It was very beautiful on the first day. Yesterday I couldn't attend. We have kept a very nice robotic angioplasty case for you. With me is Dr. Manoj Agrawal, my colleague. He is a senior consultant, cardiologist and director of Cath Lab. Rufus is a FNB fellow. And we have technician Sandeep and Kiran is the nurse, male nurse. So this we had this robotic system 15
sir, first
days
time
back.
I am feeling very
Till
envious
now
about.
we have done 10.
That sir, I am feeling very envious that you are comfortably sitting and without the lead apron you could able to talk in the live transmission.
Yeah, that's
Thanks
the beauty of this. You
thanks for
don't
the
have to
Go
take
ahead.
the lead sheet and radiations and everything.
Okay.
So we have done around 10 cases. Some of them they are really complex. If time permits, we'll show some ostial left main, ostial LAD, SVG graft, bifurcation, everything with intravascular ultrasound with OCT. We have all done it. We have kept a very interesting case for you today. And Dr. Rufus will brief you about the case and show you the system. Dr. Rufus, go ahead, please.
Rufus is our interventional fellow in Apollo. He's quite good. Go ahead, Rufus.
Yeah. Rufus, you can go ahead, please.
Slide 1.
We are able to see the slides, Rufus. Okay.
Slide 1.
Rufus, they can see the slide.
Before going to the case per se, we are going to introduce the robotic system first.
Okay.
Currently, the robotic system is marketed by the Siemens Healthcare. The first generation of robotic system got FDA clearance in 2012, and the second generation for coronary intervention got cleared in 2016. For peripheral intervention, the CorePath GRX FDA cleared in 2018. So, for the robotic system, we have two arms which is attached to the normal cath lab. One is the interventional workstation, which is kept in the console room, or which is a dedicated radiation-free cockpit can be made in the cath lab and kept. Second thing, a robotic arm which is fixed to the bedside. So you are currently seeing the robotic interventional workstation which is kept in the console in Apollo Hospital. There are three knobs. The green color knob is for the guide wire, guide catheter. The it has the robotic arm has only the wires for 0.014 wire. So the guide catheter needs to be parked in the ascending aorta. Then we can take over by the robotic system. The middle one is for the guide wire. And the last one is for the balloon or the stents. The guide wire and the catheter can be forward and backward push, and it can be rotated. And the stent and the balloon can be passed only forward and backward. There is one more switch which is a blue color, which is a turbo switch, which helps in taking the guide wire or the balloon from in the catheter very fastly. So this is the robotic arm which is fitted in the Apollo Hospital to the bedside. We have the robotic console with the robotic arm and the place for the robotic cassette to be fixed. This is the robotic cassette which has three ports. One is for the guide Y connector, another one is for the guide wire, and the next one is for the stent or the balloon. We have one more extra port which only we can keep the wire in place, but it cannot be functioned as forward or backward movements cannot be done with that port. So this is a small video which will help you and understand you better. Once the cassette is fixed to the robotic arm, it has multiple ports. One port is for the Y connector and a touch screen which can be used for unlocking the system. There is a linear drive which is for the guide wire, for the stent and the balloon to be moved forward and backward, and the rotational drive which is used for the guide wire, which can be rotated forward and backward along with rotational motion can be done. So once the Y connector catheter is placed in the ascending aorta, the Y connector is fixed to the robotic arm, and the guide wire and the balloon is pushed into the guide catheter, and it is attached to the system. Then the operator from the console room can start operating. It is not only this much, there are some of the advanced option is also available. If you see the real advantages of robotic intervention, the primary operator will get 95% degrees in radiation. The second and the foremost important one is there is 20% degrees in the geographic miss because of the sub-millimeter measurement and 1 millimeter precious positioning of the devices.
Rupas, you show the case.
So this is the
Time will
advanced
be,
manual.
show the case
So for
directly.
guide wire, we
Case.
have spin and wiggle, and for the
Show the case, Rupas.
so now we are directly going to the case. This is a 60-year-old male who is a diabetic who presented to us in May 2022 with acute inferior wall MI. That time we did a PCA to RCA with a single drug-eluting stent. Then he developed an acute kidney injury, so we have planned for a state procedure later. At present he is asymptomatic. His creatinine is 1.1, ECG shows Q waves in lead 2 and 3, echo shows a mild LV dysfunction. This is the angiogram which was done in May, which shows a focal lesion in the proximal LCX and a long tubular lesion in the OM. The LED, distal LED shows a borderline lesion, and the RCA was totally occluded, which we have fixed with a single drug-eluting stent. So already we have taken the femoral access, and the guide catheter is engaged, and we have loaded the guide wire and the balloon.
I think, Rupas, I think I'll take a, see this, if you see this L6 lesion, it's a long lesion, and there is quite a good amount of tortuosity. It will be a little challenging to pass the guide wire, but we'll try. And now the guide catheter is engaged. So this knob is for the guide catheter maneuvers, which is fixed now, but you can make you can move forward and backward and sideward also. Now I go for the guide wire, and guide wire, we have this knob for the guide wire where you can take forward movement and downward movement, a backward movement, and we also have a top row which we can move faster. So I'll just put the guide wire. I'll use the turbo to move the guide wire.
Right now, we can't see the, if you can focus the angio screen where the
So
wire is. There we go, perfect. So you can see it moving up the
Now the
guide
guide
there,
wire is in
and
the
come to
top. Now we have many movements. You can see the movement. Guide wire can be moved up. This is guide wire movement. We just want to show you different movements. You can tip, there's a R-over movement, wriggle, you can spin, you can constant speed. A lot of movements are possible with this. The beauty of the system is guide wire maneuverability. Excellent. You have many maneuvers. You can spin, you can wriggle. You can, if it's going to branch, you can take it out and go in. So a lot of flexibility is there. Now we have to take, and also you can go millimeter by millimeter. So I'm just trying to take it now to the circ. I'm moving the guide wire forward, and I'll inside where just fluoro, please. Fluoro, please. Fluoro. This has gone to the LED, so I just want take it out, move little. Now you have to, I'll just manage the guide catheter a little because guide catheter is, so now I'll try again. I just pulled back the guide catheter using robotic arm, and now I'll have to.
There you go.
Now I did some maneuver, the catheter guide wire angle changed. Now I have to take it to the OM. I have to move it. I changed the direction of the guide wire. Now it's going to the OM. Going to a branch. Now I am going forward.
Can you
Again,
show us
going
the
to the
spin?
branch.
Can you spin it there?
You want me to spin? Yeah, we'll do that. That's, yeah. Yeah, ROR. I'm doing the ROR movement, we can. It's again going to the,
So guide came back. But
guide came back. We'll take the guide forward. Guide, taking the guide forward.
now, can you feel that you have back traction on the wire as you advance the
Yeah,
guide
I'm taking the
forward?
guide where
Or is it
I'm
just
taking the
moving
guide
independent?
forward. I'll just
करें पीछे इसको करो
yeah.
नहीं
What
है।
happened? Okay.
It's not, it will not move.
It's okay now?
It will not move. It has to be enabled.
Looks like you want it a little bit forward, right? But
There is some, we are just some technical problem. We are resetting it again. I think again we are resetting the cassette because there is
but
no
it's a nice
moment is
demonstration,
transmitted.
though,
So
of how to steer.
Yeah.
just resetting, and after that we go for the.
You know,
Shall we go to the other center and
Sometimes,
come back,
you
sir?
have to, if it doesn't work, then you have to reset again and then go again forward. And the technical teams is there from the Siemens, they are supporting it.
And you
And
know, it's
we'll just,
interesting. The
reset
prior
it again
version,
and
you
it'll
couldn't
come out.
move the guide, and so that would be the issue, where you'd basically
Yeah.
wire, and then the guide would get kicked out, and someone would manually have to adjust it. This version allows you to adjust the guide, so you saw how it came out, and then he was able to put it back in.
Okay. How commonly are you using this in your place now?
And
We,
the-
don't, we have good fellows who are hungry to touch the wire, so we don't use it very much.
Okay. Sir, I think we'll go to Calcutta and come back till it's adjusted. Is it okay?
Yeah, you can go to the Calcutta, come back.
Okay.
We'll just reset it again.
No problem.
Take 5 minutes and then we move forward.
Okay, sir.
Fine.
Thank you. Rath sir, we are with you again. Dr. Rath?
Yeah.
Yeah.
See, when we were off the camera, what we did is we reset the cassette and readjusted the guide wire, and we used a 2 millimeter balloon with the help of robo. We took it and dilated. We measured the distance of the length of the lesion also.
Can you show
We'd
the
like
scene?
to show you.
Yeah.
Just show the,
Rame, previous injection,
yeah. Just,
previous. Yeah, it's okay. Then,
you see this, we have readjusted the position of the wire. It's very nicely fixed, and we dilated with a 2 millimeter balloon and all throughout. And we did the measurement also of with the help of robot. You can measure the length of the lesion also. It was around 34 millimeter. So that's what we did it. After that, what we did is now the guide catheter is very nicely fixed. So what we did is there is provision to fix the guide catheter. We fixed it so that guide catheter doesn't move. And after that, now we are taking a 2.25 Giants Alpine stent, 23 millimeter for the distal part. We'll move with the robo. We will use the turbo and move it to see the guide stent going first. We'll take it first off to the guide catheter, mouth of the guide catheter, and then we go
That's a turbo
this we
function,
are
a
going
daughter
to,
function will be
by
using.
daughtering we'll take it, and that because it's a little
Yeah.
tortuous vessel, little daughtering means it's just same daughtering effect. You see it's going very nicely,
Yeah.
just crossed the serve, gone into the OM.
Yeah.
I think this is, we can go by millimeter also.
Inject.
It's very precise movement, you can make it. Now I think just do a check,
Cine.
We can bring it back little. It has gone too far. So just check,
One cine.
little back.
Looks pretty good there.
That's okay, sir.
Yeah,
Yeah.
fine. Just check it. I think that's fine. You can go. You can go now, dilate.
So
Well,
what's happening
the
in the
giants,
room, they're inflating.
alpine.
So this system
The
still does require
2.25,
somebody in the
23
room
giants
to
are
do
fine. Go up to 16,
inflations and
becomes
loading.
2.5 and deflate now. I'll bring the balloon little out to the circumflex and dilate it again, and also we can measure it. So I'm just taking it out where balloon just yeah. Just check. Yeah, just dilate it here.
So Rufus in the room is
Yeah,
dilating.
I think yeah, fine. Fine, okay, fine. So I'll pull out the, just it's around, you can take a 15 or 18, 2.5 stent. I'll pull it out, the balloon. Out, balloon is out.
So
I'll take the turbo and take out the first.
So can you, if you wanted to load the IVUS catheter or OCT catheter, can you do that with this system too, or no?
Yeah, there is a auxiliary port, we can do it through it, but the main port, if you do it, there is some, chance that catheter may get damaged. But we did in 2 cases to the main port. It was working well, but the movement is by like this. So there is chance that
Yeah, because of the super short
this will
monorail,
cross
it
the,
can be a problem.
catheter.
I was were able
Yeah.
to do comfortably. OCT,
So,
there were some challenges too.
but we did it with this system. It worked twice. We did it. We'll do it today also. So just take out, and I want to fix a 2.5 18,
I think we take
2.5
2.75
18.
2.75.
Okay, 2.75 18. Okay, fine. Things here, the 75% of the job is by technicians, 25% by this cardiology to operate the console system, and you need 2 persons, one technician there and one sister, and the cardiologist can sit here. It's called robotic assisted technology supported angioplasty, because technicians are the main persons. So you don't, when you apply your professional fees also, is cut in half. Half goes to robo and half for you. So be careful about promoting this technology. So, these people were asking to apply the insurance company. I'm sure those fellows will tell, if robo is doing, why shall we pay the professional fees to the doctors? We'll split it. So
The
should
doctor
be
is
really
operating now,
careful
sir.
about it.
Still you are operating the robo.
Yeah. But then why that means you are not efficient enough, so you take the help of robot, that's what they'll tell. But the beauty is the no-touch technology. You don't touch much, don't manipulate. What I like most is the maneuverability of this wear and precise maneuver of the balloon and stent. Very precise movement, 1 millimeter by 1 millimeter, and many ways of rotating the guide wire tip. So
They're
that is the beauty of
they're
the
showing
system.
now the loading of the stent, I think, sir.
60-70% of the patients now, existing cases, what you do,
Yeah.
60 to 70% you can do with robot. only with patients with CTO and calcified lesion, very, very tortuous vessel, you will not be able to do. We are just learning. We have done 10 cases still, but we can see that the advantages are many, but in future the technology will grow.
Yes.
And I'm sure it's very excited. I'm really excited because as I am becoming old, I may not be able to take the load of the red set and take the radiation. So this will be more useful for me,
sir, they can see the
elderly
loading of the
cardiologist, rather
balloon.
than the
Sir,
young
I think
ones.
that just,
Ready?
can you just show them, Rufus, the loading, what you did just now, for sake of everybody?
Yes.
Yeah, just Rupas, can you show the loading? Focus on the loading.
Yeah,
I
yeah.
already loaded. They'll show it again.
Yeah, we just
Guide
saw it,
that.
sir. We just
So I
saw it.
move on. I move on to take this next stent. So I'll use the turbo so that it moves fast till it reaches the.
OCT.
Then I go step by step.
It
So
also has a
now it is
measurement
going
feature, so he doesn't have to
easily.
be on fluoro that whole time, so he can see.
Yeah,
but
yeah,
he's just
there's a
doing it.
measurement feature. You can measure the little more, I think.
You can come
Back,
back.
yeah.
That should be okay.
Okay.
I
That's
suppose.
okay.
This,
Looks good.
yeah, I think
Go ahead. Up.
you can dial it now.
Go again.
I'll just take it down, the balloon, and then you can do again dial it. Yeah. Yeah, just dilate it further. Dilate it once more. Okay, deflate.
Take it back.
I'll take out the balloon.
Take the guide wire also a little bit out. Too much guide wire.
Where also I think it's
That looks
gone.
nice.
What is okay? That's bent. I can pull out the wire little. Yeah. Okay. So you want? Okay, I pull out the wire little. You want to do the OCT? Take a suit.
Yeah, why don't you do a final one just to
Dr. Rath,
confirm
we'll
everything
try-
looks good? And
Yeah.
then- But we're gonna go
Yeah,
the
yeah.
other room.
That looks good at the final injection.
Great
Uh,
job.
Let's do the
Try
OCT
OCT
then.
through the main port.
Let's do the OCT and
OCT
just.
through the balloon port.
Yeah. So I think you saw the movement of the balloon and the stent, both stents, two stents. It was a little bend also. It went, this turbo, this movement of, doctoring movement of the movement that it is there, it helps the balloon and stent to go in tortuous bend lesions. So you saw it how it went very smoothly, effortlessly. We'll try to do the OCT. Now they're connecting the OCT catheter. We'll take it with this usual port and we'll see if it works or not. If it doesn't work, gets damaged, we can go to the auxiliary port and take a OCT.
We'll do it this way.
I think there are a lot of development taking place.
Let it,
In future, you can, with this, you can
check
put
it.
the second where you can also do the we can do a bifurcation also, but again, you have to use the auxiliary port for the second wear. You can do, but I think a lot of development is going to take place in this technology, and you will be able to do more and more complex cases with this. But the movement of the guide wire and movement of the balloon and stent has been to some extent perfected. The guide wire movement is fantastic, I can say.
Yeah, it tends to work a little better with balloons because the shafts are stiffer, but we'll see.
OCT, the initial
Yeah,
portion,
this,
we have to be extremely
we'll
careful.
see this.
yeah.
I think they are loading the OCT catheter. OCT and IVS, all catheters you can use, you can push through this robotic system. There's no difficulty, only because of the movement like this, there's pressure on this. So there is the inside of this, there is chance that may get damaged, all the fibers inside the
So let's
IVS
see,
and
move,
OCT.
move,
Okay.
move the
So
OCT.
now it's loaded,
let's
now OCT catheter. I'll just take the OCT catheter.
Again, turbo.
You can use turbo, no?
Huh? Yeah.
No, I'll not use turbo. Turbo will use more pressure.
it going?
So I think we'll go by.
नीचे दिखा. Okay. Okay. No. Where is the catheter? Huh? कहाँ है?
Sweetie, we're not able to see it, sir.
Is it going in?
Where is the catheter?
Yeah.
I don't see it.
It's going.
I don't think so.
You know what? Another.
There it is. Go now.
Yeah, there
Go
it
forward.
is. Okay, we'll take the catheter.
It's not
Yeah,
moving.
no,
Not
going.
moving.
It's not moving.
Not moving.
I think we can use the auxiliary. Yeah.
Not moving.
We'll go to the auxiliary.
He is not moving only.
Now let's see.
He has to.
Yeah, not moving.
Okay, take it out. It's
I think you can sort out.
Now it's moving
now
now,
it's
see?
moving. Now it is moving.
No, it's moving now. Now it's
Yeah.
going.
Okay.
Just show the
It moved when Rufus pushed it.
pluro.
Rufus, you can advance it otherwise.
The fellow is the best type of robot.
I think it is not recommended. They don't recommend it's moving. Moving? Okay, go ahead. Show the.
Fellow assisted.
Yeah, it looks like
Robo guided.
No, robo assisted. Not fellow is
We need to see Rufus. We don't believe it.
fellow give. So, is it just see if the
It's going.
is it moving or not? See, yeah, it's moving. It's robo assisted, not fellow assisted. It's just moving. Whether it's imaging or not, I don't know. But catheter
I think
is
even if
moving,
it that
see.
much comes, it is enough. Now it's fine. We are beyond the stand.
Yeah,
Great.
yeah,
Enough,
don't
sir.
Go further. Don't go further.
Okay, fine.
We can come back
Yeah,
a little.
back
I
a
think.
just
little.
pull it little.
take it
We
back.
can come back a little.
Yeah,
because
I'm coming back. I'm coming.
Rufus, come back a little bit.
Take it back. Take it back.
Yeah.
Take it back. Yeah.
we just tell the patient. Give some nitroglycerin before. What are you doing, Rufus? Yeah, imaging. Not moving. Okay.
Srinivas, the catheter moved, but the image did not. I
Okay.
think the rotational thing will not work here. So
Ah,
we
I
have
think
to
so.
go through the auxiliary port only.
Yeah, I think.
Yeah.
It is very tough, I think, on it.
So
That's why it's not
something
taking the
which is-
picture.
something
IVS
which
you-
is- something which is digital.
Other day-
No, IVS we tried the other day. We did not get the image.
Okay. Okay, anyway.
So something which is
I
a
think
digital
this,
array probably will move.
I think it is not reliable.
Okay, we'll
to
take it
put
through
a,
the auxiliary port and then do it.
Image
Okay,
catheter through
take
this.
it out. We'll
I
go
think
through the
the
auxiliary port.
company also doesn't
What's
recommend.
nice is
I
you
think
can
we
still
take it
maintain
out,
control,
go through
but
this,
you just do it through the side auxiliary thing, which allows you to do
Yeah.
what you need to do.
I think
Yeah, we'll
take
just
that
do
to
it
the
to
auxiliary
the side
port
We'll go
and
to the auxiliary
if you
port.
want
Take
us to
a
come
minute.
back, we'll come back again. Can we go to
Yeah,
Kolkata?
I
please?
think you can.
Yeah.
You can.
Thanks,
we
that was
will
a
take
great
a image. You can
demonstration.
go to the other lab, and in the end, you can come and so come to us and we'll show you the OCT image.
Thank you, sir. Great
Okay, I
demonstration
think,
of two stents
I
placement
don't know
in
whether
OM.
we'll have time. You have 10 minutes, I think.
No, we
And
can-
if you have
we'll
time,
come back.
just come back.
Okay, sir. Right. Thank you.
Okay, fine. Then go ahead. Go ahead to the.
But we had a great demonstration of two stent placements in OM and the robotic guided. Thank you, sir. We'll come back if you want us. Rath sir, Manoj, we are with you.
Yeah.
We
Yeah,
can
yeah.
see.
We
Looks
put
very
the
nice.
OCT catheter from the auxiliary port and took the OCT. You can see the OCT now. Just show the OCT.
We are able to see, sir.
Show the
Go.
OCT, Manoj.
Yeah, it's,
Where-
yeah.
Go ahead.
Ah.
So I think the
Srinivas, the
stent- both
dye
stents
clearance
are
was not
well
very
opposed.
great, so we have a
result
little bit
was very-
suboptimal images,
Ah,
but the stent expansions looks okay.
OCT now.
yeah.
So when you see this
I think
rendered
to the
stent image,
main
you see more or less it's a
If you
parallel
give
line here.
This imaging catheter
Yeah.
which gets damaged. We have tried luckily twice it came out.
The
but, I think
dye
it gets-
clearance,
because it
blood
compressed,
clearance
the
was not very
optical
great
fiber gets damaged,
because of
you
the
don't get
distal
the- so
small vessel.
To do
Yeah.
it,
We
you have to
tried
go
giving
for
nitroglycerin repeated, but that's the best what we could get.
That's what we did it. After that, we used the robot to take out the guide wire and guiding catheter. Just show the
So
robotic
Previous
withdrawal of the guide wire
the
and
previous
guide
image.
catheter.
Yeah, previous,
Just show the
previous.
that.
Go to the
Just so it, see, we are, that's the end of that's the final result. And then we are taking out the wire to the robot, just so now. Yeah, just guide where I'm taking out. We took out with the robot, and after that, I took out the guide catheter also with the robot. Just show the guide wire withdrawal, guide catheter withdrawal.
next. Yeah,
Show the guide catheter withdrawal also. Yeah, that's guide catheter also withdrawal. So most of the withdrawal thing you can do it. Only thing at this moment, if you want to do imaging, you have to use the auxiliary catheter port.
All right, well,
So
thanks
that's
so
the
much.
end
That
of
was a
our
good demonstration.
Thank
Good
you,
to
thank
see
you
you.
very much. Thanks, bye.
Very nice.
Thank you, sir. Great demonstration, and finally we could see OCT also somehow. And congratulations for sitting comfortably in the console room and demonstrating everything to us. Thanks to Robo. Anyway. Good, sir.
Thank you to the whole
Thank you
team.
very much, Srinivas.
Thank
Very good meeting. I really enjoyed it. Day before yesterday, I was not the day before yesterday.
Thank you.
Cases were fantastic. Very varieties of cases from variety of lab, lot of learning points. I think it was the best meeting of all amongst all your meetings that you have done till now.
Thank you, sir.
Okay, thank you, Dr.
So nice.
Dr. Srinivas, and thank you.
Yeah,
Thanks, bye.
Ajay also is appreciating our robotic demonstration here. He is with me.
Yeah, thank you.
you.
Bye. Thank
It's
you,
a
Ajay.
race.
Thank you, Ajay.
It's a race for learning between Rufus and the robot. What can I say?
Thank you, sir. Thank you.